Every year, more than 100,000 people are diagnosed with leptomeningeal cancer, and yet we do not have the tools to prevent, diagnose, or treat this disease. The Leptomeningeal Cancer Foundation is here to change that. Working with medical experts, researchers, patients, and their families, we will raise awareness, educate patients and healthcare providers, and support research. Please visit us at lmcancer.org and follow us on social media. We are here to support you and ensure that you never feel alone.
Hi, everyone. We are so grateful that you are taking the time out of your day to join us to discuss this important topic. I am Helene Bader, founder of the Leptomeningeal Cancer Foundation, and I started this organization in honor of my amazing son, Theo, who died last February at the age of 17 from leptomeningeal spread after a melanoma diagnosis. And as many of you know, information is so hard to find. So my goal with this organization is to create education around this disease and to build awareness. Joining me today to help moderate the Q&A is Kyle Greenemeyer, and many of you know Kyle from her leptomeningeal disease community support group on Facebook, which she started with her sister Brianna, who, like Theo, had leptomeningeal spread from melanoma. And as you can tell, today we are doing things a little differently. We won't be on camera, but we are still having an engaging conversation on this important topic. Good presentation, followed as usual by a Q&A session. So now it is my great honor to introduce our presenter today. With us today is Patty Wilson. She is the CEO and Executive Director for Hospice of Green Country in Oklahoma, as well as the Hospice Administrator. She is also the Home Care Administrator for Green Country Health Innovations. Patty has worked in the human services field for over 30 years with experience in in-home services, case management, counseling, and nonprofit administration. Formerly, she was the executive director of the Crisis Center for South Suburbia and the executive director for the Hellenic Foundation, primarily assisting seniors with services to maintain their independence. Before accepting the position with Hospice of Green Country, she was the director of resources, information, and case management for Life Senior Services. Welcome, Patty. We're so glad to have you with us today. And now I will turn it over to you.
I'm so happy to be here. Thank you so much for inviting me. And I hope we have a great discussion today. So I will be moving the slides along, but pardon me if I make any boo-boos. So we'll be talking today about the benefits of palliative care in conjunction with cancer treatment. And then later we'll be talking about hospice care and knowing when and how to access and what all hospice has to offer. There we go. Okay, so first of all, let's talk about what palliative care is and what palliative care is not. Next slide. This is one of my favorite quotes, and I'll tell you why. But you cannot swim for new horizons until you have courage to lose sight of the shore. Now, there's two reasons I really loved this quote. And the first one is that it reminds me that sometimes we have to let go of things or ideas to find something better. And the second thing, and the second reason I should say, is that courage and suffering are not synonymous. We have many patients who reject help because they believe that they need to suffer through their treatment. They say, "I'm fine," when their doctors ask, and clearly they're not. So let's look at defining palliative care. According to the Center for Advanced Palliative Care, that's a medical team-based specialty focused on providing relief from symptoms and stress of serious illness. The goal is to improve quality of life for both patient and the family. And then home-based palliative care is a specialized palliative care delivered to seriously ill patients in the setting that a patient calls home, whether that's a private residence, assisted living facility, senior housing, skilled living, skilled nursing facility, shelter, or the street. We've had patients in all living settings. The goal, again, and the important thing to remember here is that this is about a very holistic care that is about improving the quality of life and finding out what patients need. And that sounds like isn't that about all healthcare, but I think we'll find out that maybe it's a little different. Okay. Common questions that we get. What are the differences between these three levels of care? Is palliative care in the home versus hospice versus home health. And I think these things get confused. So let's look at a little bit about what the differences are. So palliative care in home is when a patient has serious or medically complex illness with functional impairments that typically will prevent clinic visits. The eligibility for palliative care is determined on the patient's need. We'll go a little bit into this later more, but not prognosis. And then something people usually know, but it's worth saying, is that you can have palliative care along with curative care or life-prolonging treatment. Sometimes people confuse palliative care with hospice. And so what I try to tell people is you will always have palliative care with hospice, but you don't necessarily have to have hospice with palliative care, if that helps. With hospice, the patient has an illness that has been deemed terminal, or that that there is a limited life prognosis. Up to usually with a doctor saying that they wouldn't be surprised if the patient, given the trajectory of the illness, had less than 6 months to live. But we'll talk about that a little later too. To enroll in hospice, a patient must have, again, we just said life expectancy of 6 months less if their disease follows its normal course as certified by a physician. And then concurrent care, the patient must decline the care that is connected to the disease process. So if a patient is seeking cancer treatment, radiation, chemotherapy, they would have to suspend those unless in some cases for radiation, for example, a doctor is saying that they might want limited radiation for a palliative need, for example, to shrink a tumor, because that will be helping with the quality of life. But again, that's definitely not the norm, but it certainly does happen. And then home health, which kind of gets confused a little bit, is that a patient is homebound. They need some intermittent skilled nursing. They might need some OT, PT, other therapy services, but it is very limited, and they're looking at a short-term trajectory. So for example, a patient has need for wound care, and they're going to have trouble getting to clinic visits. And so their physician orders home health for them until the wound is healed. That's a pretty simplistic way of looking at it, but home health is supposed to look at a particular need and how that need is going to get better. And then the physician's order will either continue or end at that point. Okay. The clinical team for for palliative care, you'll notice on certain slides that hospice and palliative care really do have a shared care model, and with a few differences, but the philosophy typically is the same. And hopefully as the slides progress, you'll see what these philosophies look like versus, for example, home health or care without palliative care. So the clinical team, for both hospice and palliative care, there is an interdisciplinary team. And that consists of, at least for palliative care, it consists of nursing, a physician, chaplaincy, and social work, and then other therapies that the patient might need. With hospice, there's also these disciplines, but also you'll probably have home health aides. There's more involved and more provided within the hospice realm. And then the clinical team in hospice, typically the services are provided by a registered nurse or a speech or occupational therapist. Again, there is a particular order written by a physician for that particular issue that the nurse or physical therapist is coming in for. Unlike hospice and palliative care, which is a bit more holistic, you have a team, they're all coming in and looking at all your needs. Core services, again, hospice and palliative care, a lot of time you're looking at pain and symptom management, but you're also looking at other supportive needs, emotional support, spiritual support. And with hospice, again, there's personal care that's offered as well, and bereavement services. So again, and we'll go through these later, there's this sort of ring around the patient and family about what their needs are, and seeing all of these needs as a team holistically, talking about them all the time, and how can we help this person have a better quality of life, whether it's a physical need, whether it's supports in the home, whether it's environmental supports in the home, emotional needs like counseling, all the things. They're sort of looked at all together. Again, then home health, you'll have the nursing care, you'll have physical speech therapy, but again, it's very singular. The care is based on the singular aspect of what is being treated. And then when we look at visit frequency, services are based on, for palliative care, on what the patient needs. And then for hospice, the frequencies are based on patient need, but also there are regulatory requirements. And we'll talk about those a little bit later again, when we get into hospice a little bit more. And then for home health, the patient requires frequent reevaluation for care based on the condition or the symptom that the nurse or the physical therapist or occupational therapist is going to the home for. Reimbursement. Okay, so in palliative care, and a lot of this, I want to say, depends on the state you live in. Medicare is for everyone, but then when you get to Medicaid reimbursement and obviously commercial insurance, that is going to be based on what the individual has or doesn't have, but also what the state is will pay for. So, for example, up until about a year ago, I'm going to say, just looking at hospice care, there was no hospice benefit in Oklahoma, and we were the only state that did not have a hospice benefit from Medicaid. And so we had to raise, individual hospices had to raise money to take care of patients who did not have Medicare or private insurance. We now have Medicaid in Oklahoma for hospice, but that's kind of just an example of how it could look different in different states. Now, Medicare, because it is national, it will be in every state, and because it's based on the person who is eligible for Medicare and not how much money the state brings into for Medicaid services and what they'll pay for Medicaid. And if you have any questions, we can talk about that later. But palliative care is a little different, although there is limited Medicare billing, and that is based on where the patient, if the patient can get out to a clinic or is homebound. There's also nonprofit organizations that apply for money to take care of patients in the home for palliative care. So there's different models of delivery. And again, that's based on different states. But you know, there's all sorts of different models for palliative care. And I'm very happy to say that we're seeing more of them in Oklahoma now. Hospice, again, we just talked about for Medicare, if they're Medicare eligible, the patient elects hospice, and there's some nuances, but basically it's Medicare, Medicaid, or private insurance. And then home care, again, also is paid through Medicare, Medicaid, and private insurance. Okay, so let's talk about what is different about the care team or the organization that's providing palliative care. I think people sometimes ask, well, I get the question, so what makes, a palliative or hospice nurse different from a nurse that's in the hospital or a home health nurse? And I think that there are some nuanced differences. All nurses are wonderful. They are highly trained, but just like doctors, they are sometimes trained in a niche. So they are receiving particular training for what they are going to be subject matter experts in. And so home health is different than palliative care. And specifically, the biggest differences are, well, let's look at like hospital nurses versus palliative and hospice nurses versus hospital nurses. And so one of the things that's different, and that we've seen over time at least, is that if you have a nurse who's only been in the hospital, that doesn't always translate to home care. Home care is a very different feeling. You become much more ingrained with your families because you're in their home. And so you have to be really good at developing those relationships and making sure that you can sustain the kind of relationship that you need with the families and the comfort level, because you don't know the kind of home you're going to be walking into. You could be going into the home of a millionaire 1 minute, and the next minute you could be going into the home of somebody who doesn't have a front door. And is living in pretty dire conditions. So I think that having that comfort level with in-home care is really, really important for members of the clinical team. Also, being really aware that we're looking for management and looking at people who have serious conditions, but not necessarily curative care. So we're helping people with pain and symptom management, but not necessarily saying, oh, wait, this thing is wrong, and this thing is wrong, and this thing is wrong with someone. And so we're going to go after all those things and cure them. And then having an understanding of being able to assess what somebody needs in their home environment and being able to offer those things in a sensitive way, and the fact that we will be there 24/7 for you, where that doesn't necessarily happen in home health. Understanding how to the kind of funding sources that will be available and the resources available to people. It's really important for your social worker to really be a medical social worker who understands the resources in the community and how to help the patient and the family bring them in the home to get them what they need for that better quality of life. But also, if you're really lucky, you can have an LCSW who has a therapeutic background and knows how to help people really look at how emotionally they're being affected and their families are being affected by the illness and all the things that are going on for them and their families. I'm going to take a drink, sorry. Okay. So again, let's look at all, if not all the things an assessment will have for nurses and social work. A great deal of what will be on an assessment will be looking at pain and symptom management, what's going on. A lot of times there will be, a patient will have multiple doctors with multiple prescriptions. And sometimes those prescriptions are not maybe necessary completely, or sometimes they're duplicated. We've seen a lot of times where patients come on and they have 3 medications for anxiety, or 3 medications, or, 4 medications for sleeping, because they went to one doctor and they prescribed something, and then their other doctor, again, they went in to see that doctor, and that doctor happened to prescribe another sleeping pill. Well, and then a different doctor prescribed a sleeping pill again. So we're really looking at all the medications and really working with all the doctors that the patient has in palliative care and in hospice to look at, what are the reasons why a patient is taking all of these different medications. A lot of times people come on service and they DC a lot of the medications because they're just not helping them. And in fact, they're counterproductive. And so we have to be able to talk to their other providers. So it's really important to have that kind of really collaborative communication to help not only the family with decision making, but also talk to the patient's other doctors, so that everybody feels like they're part of this team around the patient. We talked a little bit about counseling for patients, and then there's also counseling for families. Sometimes it's all together, sometimes it's separately. Really looking at, again, this family, or the patients, the unit around the patient, and who is there involved in care. What maybe has been happening within the family that needs addressing, emotional needs that need addressing to help the patient get a better quality of life, feel like they're getting their emotional needs met as well as their physical needs. Advanced care planning, that's very important. Oftentimes we see patients in hospice who have never looked at advanced care planning, and that isn't about, do I have a DNR or don't have a DNR? That's a small part of it. It's much more about, okay, how would you like to be treated if you have to go to the hospital? What decisions would you like to make as far as artificial nutrition and hydration, if that becomes the need? What decisions do you want around, for example, CPR? But also decisions about how do I want to, when I die, what do I want to happen? Do I want to be buried? Do I want to be cremated? I mean, I have an advanced directive, and currently I don't have any life limiting illnesses, but I think it's important. And I'll share my own personal story with you. Both my parents were on hospice at the same time. They were both quite ill. My mother had advanced cancer, and my father had Alzheimer's, advanced Alzheimer's. She was his caregiver, and they were both declining precipitously, pretty quickly. And so my brother and I sat down and did an advanced directive with my parents. And I will tell you, at the time, we thought it was important and great to know what their wishes are and were. But after my parents passed away, the advanced directive took on a big importance for our family, because we knew what they wanted and we honored their wishes. And I think people are often surprised that when their loved one passes away, the people that will come out and say that you did things wrong, or you didn't do the thing that they wanted, or that's not how they would have, what your parents would have wanted. And so I always tell people the biggest gift that my parents gave my brother and I was an advance directive on their care, that here are the decisions they made, the things they wanted, and that we were just there to honor them. The next area would be psychosocial and caregiver support. We talked a little bit about that the counseling, the kind of support, because caregivers are exhausted. Sometimes their trajectory for illnesses are years and years, and the caregivers are exhausted. I think it's the Caregiver Foundation that put out a report that said that 33% of caregivers die before the person that they're caring for because they ignore their needs and become ill. So I think that's a pretty compelling statistic. And I think that's something that we need to keep in mind as we look at how to support not only the patient and the family, but the caregivers who are doing amazing work and offering their gift of love, through this caregiving. Environmental support. So in home, we'll come in, a palliative team or a hospice team would come in and really look at what the patient and family need in the home. Does the person now need, for example, to look at rails in the bathroom? Or are we looking at, do we need a hospital bed in a room that is more open so that the person isn't tripping when they're trying to get to the bathroom? Or, oh, let's look at you have loose rugs. Should we pick up the rugs and maybe make it so the person has less of a trip hazard? Are there wires in the home that we could look at? Does the family have fire alarms? All sorts of things. So I think that's, something that people sometimes don't think about. And I think it's really important to make sure that there's enough environmental supports in the home. So again, the person is able to live in their home happily with high quality, no matter what the illness or what the trajectory of their illness. Connections to community resources. I think that's really very important to look at with regard to understanding what the person, again, is going to need to be able to stay in their home. Do they need to be connected to resources for food? Do they need to be connected to resources for utilities? Are they able to pay their rent? What is, sometimes people say everything's fine, and then we find out they're one paycheck away from not being able to stay in their homes. Or a really extreme one for us was people who had bed bugs in their home, and they had them in their home and they had them in their car. And unfortunately, they needed all of these resources and help to be able to stay in their home. So you'll get that kind of an assessment too. There's spiritual care. I think I'm going a little long, so I'm going to go a little quicker here. Rehabilitation therapies. And again, we talked about the care coordination is very important with all of the other providers that the patient may have outside of the palliative and hospice team. Medical reconciliation, we talked about that, making sure that the medications are correct and appropriate for the patient's need. And again, planning for end of life care and timely referral for hospice if appropriate. When should you seek palliative care? So this is, it can be a little complex, but I would say to people, if there's a chronic illness or disease or a complex group of chronic illnesses, is it impairing functional, somebody's functional or creating functional impairment, sorry. And are there emotional and spiritual needs for the patient? And again, is it affecting my quality of life? Is the disease or the chronic condition or conditions, how is it affecting my life? How can I feel better to do the things I would like to do given my physical limitations? That's a great question to ask when you're looking for palliative care. Oops. Okay, so we've moved into hospice care. And again, we talked a little bit about this, but the focus is on caring and not curing. It's palliative care with additional resources, actually a lot of additional resources to address the complex medical, physical, and emotional needs of the patient. And specifically, a lot of those extra needs, including the medication, are paid for through Medicare or through Medicaid, whereas more of a limited number of those needs would be paid for through Medicare and Medicaid for palliative care. So you're looking at more resources. The patient's condition is, let's say, declining. The doctor is saying, well, we've tried, certain, all of the curative methods that we have, and still we're seeing decline. We're not seeing an increase in the person's ability to be cured. But another, thing to look at with hospice is that unlike palliative care alone, the patient must qualify for hospice based on a diagnosis. And that is a little bit different depending on where you live in the country. I going into this, I thought it was the same all over the country, but it could be slightly different. But for the most part, it's the same. They're the same diagnoses and things that need to be present for hospice to be indicated. Depending on the diagnosis, some curative treatments will be suspended. We talked a little bit about that. Thank you, Helene. I will move it along. But that some curative treatments will be suspended. A physician would have to certify that given the path of the illness, that the patient might have 6 months or less to live. However, patients do go beyond 6 months. And the focus is on helping the patient through the natural decline of their health, given the chronic condition or disease. Okay, so again, we talked a lot about this. Here's the team, right? You have, and the other thing, one of the things we didn't talk about with palliative care is the addition of volunteers. Medicare requires hospice to train and maintain a volunteer pool to help patients and family with their needs. It might be helping with shopping or light housekeeping or extra needs in the home. We, for example, have a pet program, and we help with walking dogs and their pets and bringing them to their vet visits and things like that. So volunteers are wonderful in being able to do that. And then with hospice team, there are 2 other specific areas, which is the home health aides, which are absolutely the people and they're wonderful, magical people who are in the home more than anyone else, and really do provide a lot of relief for the patients. And then there's the bereavement counselors and the chaplains who are there to, specifically for the bereavement counselors, really help the family after the patient has passed. Okay. Obviously, patients and families are the most important members of the hospice team. They are critical in looking at the care plan and what the treatments that the patient wants, what their wishes are, whether they can articulate these wishes anymore. That's wonderful to have the family again know what the wishes are of the family or the patient, and to be able to articulate that to help with the care plan. And that the loved ones are usually the main caregivers. I think people sometimes think they're going to go on hospice and that, someone is going to move in with them. And that's not the case. The care team is there whenever they're needed. And as the care plan indicates, and obviously that changes as the patient's condition progresses, but that the caregivers do a lot of the hands-on caregiving, and that we're there to help them feel more comfortable with that, and to do all the training and help them understand the trajectory of the illness, help them understand the how the medications, what might happen with the medications, and how to counteract some of these things, but that we're always there for them, and we will come 24/7, 365 whenever they need us, other than our regularly scheduled visits, which might be every day. Doctors have a specialized training in palliative care and end of life, so they understand how a patient, and with all the needs that they have, and how their body might be declining, and what that's going to look like, also to help the family understand how that's going to look and what to expect. It's really important. The scariest thing for families is, I don't know what to expect. What should I expect? And so that's really important for us to be able to articulate that. Talked about this a little bit earlier, that hospice nurses, while they may have other training, they might have been trained in med-surg in the hospital, they might have home health training, but that they're also, hospice nurses are very specially trained. They need to understand not only how to provide the medical care and how the body is going to decline based on the diagnosis that the person has, but also have the sensitivity and be able to form that relationship with the family to help guide them through the medical portion of what's going to be happening to their loved one. Social workers, again, integral in helping people with resources, but also, again, that relationship, providing that emotional support, being able to sit and ask the question, how can I make your day better today? What can we do to, to help you today? And it could be, something that is unexpected. My mother, I'm going to talk about a chaplain. My mother had a chaplain who was Jewish. My mother was not Jewish. She was Greek Orthodox. And, but she loved him. He took the time to learn how to play on his guitar some Greek songs for my mother. And she just loved that so much. She was so appreciative and she always looked forward to his visit. It was so very wonderful for her to be able to have that and to make that connection with him in that way. He was very special. Home health aides, again, feeding, bathing, meal preparation, assistance with chores, but also, again, that personal connection. They're doing a lot of personal care. That person is relying on them for the bathing and that personal care aspect oftentimes, and they develop a very close connection to our home health aides. So again, very important part of the team and important to the families. They love their home health aides. We talked about volunteers, so I'm not going to go into that, but they help with our pets. They help, just bring extra joy and support into the home. We have volunteers who provide massages. We have volunteers who will, make gifts and drop off things for family members, do some light chores. There are all sorts of really wonderful aspects to the volunteer program, and we really appreciate our volunteers. Chaplains, we talked about the spiritual, doesn't mean religious, by the way. And so much like for my mother, he provided that spiritual support for my mother through his playing songs for her and just having that relationship with her, and didn't necessarily have any religious discussions at all. But they can, of course, and of course they're there for that as well, to be able to provide that kind of spiritual support if that's what's requested. We have our chaplain often is the person presiding at the patient's funeral because that's how close they got to the chaplain. And again, interdisciplinary group, that's all of these people together, meeting at least every 15 days for each patient to have a discussion. But let me tell you, and if you hear the little boops on the side of the screen, unfortunately, that is because we have teams, and that's the team talking to each other all day long about what's going on for the patient and what the patient might need. Okay, I'm going to go through these really quickly. Referral, because we've talked about this and I know we don't have a lot of time. Life-limiting illness, they're ready to stop curative treatments and that really depends a lot on, again, the diagnosis and what the person is coming to hospice for. But what we hear more often than not is, I wish I would have found you sooner. I mean, that's mostly what we hear from patients and family. Eligibility, a doctor would have to decide if the patient can enroll in hospice. Anyone, by the way, can refer themselves to hospice, but there needs to be that medical eligibility there. We talked about payments, so I'm not really going to go into that much. We've talked about the care plan, and there's a lot of aspects to it. And again, if you look at the care team, you'll also understand what all is involved in the plan of care. Everybody talks about what's needed in different areas to help the patient and family with the patient's needs and the quality of life for all of them. We'll set up care in the home, and that means bringing all the equipment. Hospice will bring all the equipment necessary for the patient and all the medications necessary for the patient's palliative needs. and wherever they call home. Visits are on a regular rotation, given what the patient's needs are on the care plan. And again, there's a lot going on when there's a visit. There might be adjusting medication, but it's not just about the visit. We are available 24/7, 365, and that's really important because they need to know they can call us at any time and we will be there. And then hospice, after a patient passes, removes equipment, provides grief support up to 13 months after the patient has passed away to the caregivers and family of the patient. And that's really important because we don't want people to feel as if we've formed this great relationship and now we're gone. We want them to feel like we're still here for you and that we are going to travel the rest of this journey. I think that's it. Oh, good. I almost did it, Helene. About a minute
No, that
over.
was great, Patty, and thank you. I just wanted to make sure we had time for questions because we do have quite a few. And I think that, was really helpful in terms of kind of laying out some of the specifics. I think a lot of the questions we get are connected around understanding palliative care and really knowing that that is something that anybody with a condition that needs extra comfort care should seek out. I think the word palliative is really confusing because it's not a commonly used word. So it's something that people don't realize it doesn't really attach to hospice, even though they're often served by the same organization or by similar nurses. They come together a lot of times in that way, but they're really very different if you don't end up needing hospice, right? Like palliative is something that can be given to anybody.
It can be separate.
Yeah.
Absolutely. You will always have palliative care and hospice, but you don't necessarily have to have hospice with palliative care.
Right. And as I mentioned in some of the information when I was promoting the webinar to make sure people knew that we were going to be doing this, the thing that I felt was when I got a call from hospice care and my son had, we were going through all the treatments and everything and he seemed good, I right away said, nope, not interested because it came from a hospice organization. And so I didn't feel that I wanted to even have that conversation. So I think it's really important to understand that we would have benefited tremendously from palliative care, but didn't feel that was something we were ready to jump into because it seemed too tightly connected to hospice. So this is really helpful, I think, for people to understand that. And I think, just knowing that that is not something that, is necessarily part of hospice. I think one thing also I just wanted to point out, and I know we can't get into the details here, but there is a difference for pediatric hospice.
Yes.
And one of the things that we were told too later on is that you can continue curative care for pediatrics.
Yes.
So,
yes.
okay.
So I think, yes, I think there's nuances, but, and one of the things I know you and I talked about earlier was that there's also a bit of a misconception that if I'm seeking out treatment, all of these things are a given. Of course I'll be getting all this help, and that's not necessarily true. If you seek out palliative care, you will, but if you're in cancer treatment, the treatment is about the cancer.
Right.
It's about eradicating the cancer. And so looking at the whole health of the person and all the things that are going on for them, that's not necessarily a part of what happens unless you ask for it.
Yes, and that's a very good point. So I'd want to point that out to everybody on this call is to understand that, at any point to say to your healthcare team, we would like to have a palliative care consult. Many hospitals have palliative doctors and nurses within the hospital, or they can refer out to a palliative care, in-home place that, could come into your home to provide that, but at least you start those services as early as possible. So and one of the questions we get a lot, and so this is, one thing I want to send over to you, and I know that you did present a little bit on this, but, how do you know when to stop treatment and sign up for hospice? So are there specific ways that we, know exactly what to do if you are still having conversations, you're walking around, you can feed yourself? Would this change if you went on hospice care? So what do we look for to know? Is there something that we could tell as a patient what that looks like?
I think what typically we hear from patients is that they've had enough of the treatment, the curative. I'll speak to cancer because it's different than I know I keep saying that, but it's different than other chronic conditions. I'm sorry to say, and I wish it wasn't true that wish people could continue their treatments, their cancer treatments when going on hospice, but they're not. They're usually the group that suspends the most things when they go on hospice. They're getting a whole group of other things, but they're really looking at, I'm done with the treatment, the cancer treatment. I think that probably should start with more conversations with oncologists, with the patient's oncologist. And so for example, doctor, we run the course with this particular round of chemo and it helped me this long. And you're saying that this is a different kind of chemo and I'll be taking this now. And what's the prognosis with this chemo? Because a lot of times patients and caregivers and family don't ask that question. I mean, obviously the patient, if they're an adult. I don't know whether people don't want to know, or they just think their doctor is, hey, we're going to try one more thing. We're going to try one more thing. We're going to try one more thing with the hope that, this is going to be the one. And that's fine. No one wants to take away anybody's hope. But I think those conversations, especially I think with cancer patients, really start with that really open discussions with the doctor. There is a great, I think it's widely available now. It's called Being Mortal, Atul Gawande. And he talks about this journey with patients and the discussions that he should have had with them and that he had wished they would have had with him when looking at when it's time to stop. So I think that's probably, especially with cancer, I would say, the biggest place I would start, really having open discussions about what is the prognosis given this particular treatment. Is there a 20% chance, a 30% chance that the cancer will go away or go into remission for a certain amount of time? The numbers are out there oftentimes, and doctors may not offer up that information without being asked.
Yeah. And I think with leptomeningeal cancer, it is a little bit complicated because, the prognosis keeps changing and it's also not necessarily standard because everybody's situation seems really different. So some of the older material says a few weeks, but we've seen that with some of the trials and all of the other stuff that we've been able to extend life, and finding these clinical trials and finding these experts gives us that ability. But it is a question that comes up because leptomeningeal disease also can create some confusion and some mental health stability. And so one of the questions that we were asked is, if you're taking care of your parent and you don't think they fully understand their diagnosis, should you tell them that their cancer is terminal? How do you address that?
Yeah, I mean, and interestingly enough, I did run into this, even though it wasn't this particular kind of cancer. I ran into this with my own mother. I think that she had a very a good relationship with her oncologist, who was very aggressive in her treatment, and we got to a place where she literally was looking at me saying, this is it, isn't it? And I thought, gosh, I wish no daughter should have to be the one to have that discussion with her parents. But yeah, I think that if your parent or your loved one has the capacity to understand, certainly having those discussions makes sense. Now, that is a sticky wicket, right? Capacity and, competency and all the things that go along with it. But that's where the advanced directives come in. Mom, for example, for me, Mom, when would you want me as the POA? You named me power of attorney for healthcare, right? When would you want me to decide that it's time for hospice? If you're not having the capacity anymore, or you seem to be confused, or you seem to be having the effects of the care that is kind of clouding your judgment. So that's where those advanced directives come in. Again, especially at when someone is, looking at a very complicated illness or disease. But certainly even earlier in life, so your family knows what you want, but especially at that time, because then, well, I'm not pulling the trigger too early, for lack of a better term. And this is what she wanted. Even though she's confused now, I already know what she wants, because when she wasn't confused, this is what she told me. Does that
Right.
help?
And yeah, that does. And it's interesting because we have been talking about having another webinar on end of life planning. I think some people have expressed interest in that. And you did mention this about the advanced care plan and how important it was for you. It's one of the questions we got is, there's so much information to fill out. If you've gone through planning, you know how much you have to fill out. And if you have frank discussions with the people around you about what you wanted at the end, how important is it to have this advanced care plan? But I think you did answer that with saying it was more important for people after questioning your decisions because it was in writing. Is that what you would say?
Yeah, for me, it was very comforting, I have to say. I mean, if there's comfort that to be had at those moments, that was one of the things that was comforting me, because my mother had relatives who were very vocal about telling us what we did wrong, and how we were not honoring our parents and what they really would have wanted. And I said, "Yeah, guess what? I have it in writing." And
Right.
so, when they could make those decisions, they did. And by golly, we were gonna do what they wanted. So, it may have surprised some people, but, I,
Yeah.
I wasn't there to
So,
make them happy. I was there to make my parents, happy.
right. We have gotten a bunch of questions, and I think this is a hard one, but maybe it's not consistent, and maybe it's more consistent around cancer specifically, but are there specific ways or symptoms that we can tell that our bodies are nearing the end of life? I think a lot of people are caring for people that they can't tell, and they're wondering, like, is this the end? Are we seeing the end now? And is there a way
Yeah, there are, and that's why it's so great to have, I mean, without saying specifically cancer or this or that, yes, there are, just like there are reasons and eligibility for hospice, there are ways to tell that the body is in decline, and that it's not going to get better than this. I have a combination of really not being able to physically, emotionally take another, for example, round of chemo, and that I just want to live, and be able to spend time with my family and not be sick and not be have all the complications that go along with the interventions. And I think that's why palliative care is great, because you form a relationship with this team. They're not, there to tell you, come on, hurry up and go on hospice. But they are there to tell you, okay, so let's look at the consequences of the decisions that are being made right now, right? So I'll give you an example. So people who say, I'm just gonna go to hospice, I wanna be on hospice, but I don't want a DNR. By the way, you can be on hospice. A misconception is that people think that you have to have a do not resuscitate to be on hospice. Not true. You can have you can have CPR and be on hospice.
Mhm. Okay, no, that's really helpful.
But ethically, we have to talk to you about where your body is in the declining process, right? And what CPR will do to your body right now, what it will look like, because it's not what it looks like on TV It looks so pretty on TV, and it's actually pretty violent. Their number one goal is to keep your heart beating, and that may mean broken ribs and punctured organs and all sorts of things that will, in a more frail patient, will have them, on a ventilator. And then ultimately, probably after the ventilator is removed, that's keeping them alive, they will pass. And so that was not a good death in any realm of the imagination. So ethically, you can make whatever decision you want. Ethically, I have to explain to you what this looks like. Does that help? So here's what
Yeah, definitely.
we're
And I
seeing.
Sorry, go ahead.
No, go ahead.
No, I think it is helpful. And I think it is hard to tell for each independent person. I think one of the other questions we got was about pain and pain management and how painful things are in the end. And I think, again, that's probably varying for everybody, but how hospice can help mitigate that pain. And that is something
Yeah.
that you do, right?
I think people don't realize that we are able to give a higher level of medication because, when you are looking at life-limiting illnesses, nobody's worried that you're gonna get addicted to oxy. I mean, that's not the care right now. What we're looking at is making sure that the person is able to function to the level they want to function, but pain-free, so that they can enjoy the time they have with their family.
That's great. Yeah. And then we did get a question on how you determine how often a home health aide comes to help at the
Oh,
house.
yeah, that's part of the care plan. I mean, we may have patients that come in immediately and need a home health aide every day, just because of the functional impairments, or the caregiver is compromised. They can't provide that level of care. They're there for safety, but gee, I can't, move mom to bathe her or to do all these other things for her. So it really depends. I mean, we have people that come in and they're still able to bathe themselves and do all the things. And then later on, they, need the home health aides more and more. So that's why it's important that we're constantly talking to each other, but definitely so the whole team is getting together and talking about the patient every 15 days to make sure that we are on top of their current needs, because of the decline.
Okay. We only have 3 more minutes. I wanted to quickly get to the last question, but just basically about, different states and being treated in 2 different states, and really how to know when to step in to help out. Like, for example, this person had talked about their mom being based in one state, but the dad is not in the best of health, and they're trying to figure out when to step in and help and, figure out palliative care versus hospice.
Ooh, that's a big one. Yeah, well, so there's obviously differences in different, I mean, overall, there's some basic similarities. There are some nuances based on the state, based on the region, what resources there are. I mean, the resources in Tulsa, even just within Oklahoma, are very different than the resources in the Panhandle, where there's, much less population, there's less resources, right? So I think that really depends on the area you live in. But with regard to taking care of patients in different states, yeah, I think it's important to be informed. I was fortunate enough to be able to work in the state my parents lived in and understand senior resources. But for people who don't work in that industry, it can be super confusing. The first place I would go, if the person's a senior, for example, so since we're talking about mom and dad, I would go to the, look for the aging services or the area agencies on aging in that state. Start there, because their job, number one job, is to find out how to help you with resources in your area. And if you're looking for where those resources might be, or who to contact first, that's where I would start. Who are the area agencies on aging that have been identified in each particular state, that are sort of in charge of being able to give you that information, because they'll lead you in the right direction. There's 2 based in Oklahoma, and there's different area agencies on aging in Oklahoma, for example, based on regions. And so If you live in Tulsa, it'll be INCOG. They're based on the councils of government here.
No, that's very
Um,
helpful. Thank you. And I think those are good resources. And I hate to cut this conversation off because it's clearly very needed, but we are at time. And so I do want to respect everyone's time and their time today. So I want to just thank you, Patty, for your wonderful coverage of this really important topic. And, thank you to Kyle and our producer in the background. And really, thank you to all of you for showing up. I know this isn't an easy conversation. I know it wasn't easy for me to face when we were going through this. So I really, I'm glad that you were able to all come and listen and ask questions. This will be recorded so you can follow up. And also, we can continue having these conversations so that we can answer all of the questions. And if you follow us on social media and you sign up for our newsletter, you can stay up to date on all of our upcoming events. We will plan to have more webinars in the future. I really hope this was helpful and that you're leaving today feeling more informed and more empowered. So thank you again, everyone, and have a great day. And again, we will be in touch and we'll continue this conversation as needed. So thank you, Patty.
Thank you.